What are we going to talk about this morning? We're going to talk about an area that actually I've spent some time looking at, and that's cervical spine. So let's be practical here. What really happens? An ambulance comes rolling in, and there's some 52-year-old man on the board, and he says, "Does your neck hurt?" And he says, "Not until they put me on this board." Okay, we've all had that. And we've all irradiated people to the point where I'm sure some of them glow in the dark at this point in time. What did we get for it? How are things being coordinated? I'm not giving the ATLS talk here. I think Billy Mallon is. But understand that even the ATLS people, the surgeons, have come around on this thing, that we don't have to shoot films at everybody. The question is, who is it who doesn't get the films? So we looked at this question. I wrote the chapter in 2007, which asked a very simple series of questions. Who needs to be irradiated? And why? And what are you going to get for it? And what did we miss? And in the States, we ask, are you going to get sued for it? Okay? What do they do in Australia to you guys if you miss something? They tie you to a kangaroo and or beat you with a wallaby or something? I have no idea what they do. But in any event, let's take some things as gospel. Okay, we need to accept some things right off the bat. Number one, most studies support the fact that backboarded patients, most of them don't actually need a study. I can go along with that. They don't, because the number of serious C-spine injuries you picked up which weren't obvious coming in, real small. See, we've all had that person who, it's like, remember how they taught you to check for a step off on the C-spine? Has anybody ever found a step off on the C-spine in somebody who was neurologically, it never happened to me, and I was a neurology, I've never seen it in my whole life. Yeah, if you have a step off, you in deep shit. Okay, that's just the way it is. But you don't need to have much brains to figure that out. The helical CT, the fourth generation scanner, is fast. You can do the neck once you're in the machine between 4 and 7 seconds. That's the time interval we're looking at. And so I think that you have to understand this. You read a lot of literature on what things cost. I'm basically an economist. I'm happy to carry on discussions with you about Hayek and von Mises and all that kind of stuff, but no economist asks the question of charge. So whenever you read one of these stupid papers that talks about the charge, wrong. It's the cost. And CT costs 11 cents in electricity. What you're concerned about is the tech time, the movement time, right? If you want to do 5 views of the neck, let's say it's grandma. And does anybody here ever have trouble with old people's necks? Stick your hand, yeah, of course. It's not the 18-year-old, it's grandma. And you're saying, what's that? Well, I have no idea. Well, one of the advantages of CT around the world is you always get a radiologist involved online on time. Or you should. Why? Because that's what they do. That's how they charge. That's what they get. So just understand that we're going to be talking about plain film reading. How well do people do? What about the CT scan? And whenever I mention the word cost, I'm talking cost, not charge. Because you can charge anything you want. There was a study released 2 days ago, which is getting huge play in the New York Times and that sort of stuff, about the variance in charging in the United States in hospitals. How come it costs 5 times as much in one place as it does another? I don't know. Okay, yeah, I do know, but I'm not going to expound on that today. So you and I are going to talk about cost. Warning, there is another cost. Everyone will agree that the helical CT is faster than plain films ever thought of being. More accurate, we'll talk about that, by 34%, 35%. But there is a cost. And that cost is you're shooting 180 times the rads of a chest x-ray at some kid's neck. Is there a measurable amount of cancer from that? Yes, the answer is yes, there is. And heaven forbid you have to shoot 2 of them. Or worse than that, the resident in 2 days thinks they need another one. I mean, it is serious. I mean, there is a cost. But the cost is an opportunity cost down the road. So if grandma's in there and she's 84, do you care? No, light her up. Make her glow in the dark. You may actually treat a cancer she's already got by accident. This is not where the debates are in the country. Just understand the real debates, the people kicking butt and taking names are talking about exposure to young people versus, just doing everybody. And what you will find here in these papers is a philosophic divide between certain people who say, just do everybody. Screw it. Just put them through, right? Decreases your lawsuits, does that, bop, bop, and it's done. Well, 4 seconds and it's done. So I want you to understand that the cost-benefit analysis here is not in money, which we actually spend as a society. We already bought the CT machine, right? It's there, it's fixed. We already hired the tech time. It's fixed. It's got 11 cents on the electricity. That's not the issue in the country. It's radiation exposure down the road, and what do we do about it? So with that in mind, let's go on. And by the way, let's end this sort of cheap discussion right now. Nobody's got an MRI study. This is what we should really get is an MRI. Nobody's got that study. We have no idea. I mean, it's not that there aren't a few studies going on. But the point is, when you're moving people through an emergency department, let's say you really work for a living, and there's going to be 32 people show up through that door in the next 8 hours that you've got to take care of. And that's where I'm from in my practice. I got to see 32 people, get them through. The MRI is not a reasonable study at this moment in time, and nobody's got a paper that says that. So don't get into that kind of stuff because it's a waste of time. Flexion extension views were done in this country since the 50s. And I don't know what it is in other countries, but understand this. Nobody of credibility is mentioning the term flexion extension views of the neck anymore. If you actually have a fractured neck, how good is flexion extension? See, that's the reason we put the collar on, is to avoid what? Flexion extension. Nobody can show that flexion extension views, and you occasionally hear a weirdo. We got a weirdo at one of my places, a neurosurgeon. See, neurosurgeon and intelligence don't necessarily go together, okay? Neurosurgeons and depressive personality go together. The last thing they remove on the last day of neurosurgery residency is the personality, okay? They take it out. But believe me, he likes flexion extension views. Why? Well, I'm the neurosurgeon here. And he said, call me Mr. Neurosurgeon. I said, no, I'll call you Mr. Asshole. Because the bottom line is, the data doesn't support you. They don't care. But as far as the science go, and this course is about science, flexion extension views, I'd have no idea what you'd do with them. And so just don't do it. Bad thing. CT scans, as I said, always get radiologists involved. And I'm going to give you a phrase that you have to have for the rest of these papers. Inadequate films. Because that's how they're going to decide whether they got to send them back to get another study. What is the re-jerk reflex in the United States of a radiologist to suggest what? More films. We need a nuclear study. We need to bomb you with something. We need a drone to hit you. We want another view, right? It's like the doctors who were duck hunting. We're going to shoot in rotation. First duck comes up, the general surgeon is going to shoot. Bang! He says to the pathologist sitting next to him, run over there and see if that's a duck, okay? Yeah. Another duck flies up, and the radiologist kind of walk around, going to shoot, and he gets out of the boat and walks over. So what do you do? He said, I want another view of the duck. Okay, yeah. All right. They always want another view in this country. It's the exact opposite in England. Why don't they want another view in England? Because they don't get any more money for it. They can't charge for it. They get $1. Okay? That's it. They don't get any more money, so they'd rather sleep. And, there's a great phrase in Britain. I did some stuff in England, and they always talk about, well, we'll sort it out later. Well, that's been their entire life. But understand, they don't do a lot of extra studies. We do. All right. Let's ask a couple of other questions about this literature before we go through it. Number one, when somebody says, you missed a fracture, what should be your response? Who cares? Was it of significance? And that's why looking at a lot of this literature, when they say 37% of fractures were missed, then you look down and you look at the next line. Did you do anything about it? Because there's all kinds of fractures in grandma where you've, pulled off a little ditzel here and there, something like that. Is it technically a fracture? The answer is yes. Are we going to treat it? The answer is no way in hell. In fact, we're going to look at a study here where we missed 19 fractures. 16 of the 19, they put a soft cervical collar on. So come on now, guys. Let's ask some real questions. What are we going to fix? Okay. So, let's look at, get the first page up here. Let's look at Article 3. Now, here's my standard method of going through these things. I'm going to only tell you to circle a couple of articles, because the rest of them ain't worth your time reading. I had to read them, and I hated them, okay? So when I say circle it, it's probably worth taking a look at. What's the function of that damn book anyway? It's to take back to your institution and say, we're changing behavior on this issue, and here's the literature, and hand it to the radiologists, the neurosurgeons, whoever it is, and say, based on this, we're doing that. You send me your literature. I've done that for years. Do they ever send you their literature? They don't have it, because most of it is their literature, as you're going to find out here. They just don't read, right? No surgeon wants to read a book that you can't color, and or it doesn't have pictures. All right. Article 3. This is the efficiency of plain films to evaluate blunt traumatic cervical spines. This appears in a journal which I have a lot of respect for, and that's the Journal of Trauma. It is in general a fairly well thought out journal, but it has an attitude and an opinion. It has the surgeon's view of the world, but it's pretty nicely edited. This is from Pittsburgh, and they looked at 640 patients. They did the standard set of, the 3 views, and then they did the CT scan. Here's the phrase that ought to frighten the living poo-poo out of you, and that is 72% of the 640 patients were considered to have inadequate films. And only 6 of the 19, there are only 6 fractures found in 640 patients. Surprise, surprise. And 6 actually there were 19 fractures, but only 6 of them were found were found on the plain film. That means the CT picked up some more fractures. But they don't comment in here about the significance of what they picked up. We will all agree that they miss fractures. What they can't agree on is what's significant. But I think the fact that they said 72% of the films were considered by their radiologists that they wanted another film is frightening. Because that means you got to send 72% of people back to the radiology department for another set of films, and you all know it is not linear. On 18-year-olds, how do we do on their films? Fantastic. When you're 80, how well do we do? Poor. Just understand it is not linear. It goes like this. The older you get, the worse we are at the films. And I hate these studies because they always reference patients over 65. That means like I'm like dog poo-poo now, okay? I'll be 67 this year. I'm not dog poo-poo, but radiologically, I am, okay? Now I'm in the tough age group. And if you left the machine on and went to have lunch and came back, you're probably not going to induce a cancer in me. So it's probably okay. 3 I would circle. Article 4, CT in plain films. This is the Holmes article, again, Journal of Trauma, says the exact same thing. Inadequate films, why are we doing plain films at all? And they looked, this is pretty good. They looked at 3,800 patients. And they, in a meta-analysis of studies. And what they found out was they had a 52% sensitivity on cervical, if you take all cervical spine fractures. What we're saying is here, this number, you're going to start to hear back and forth again, 35, 40% are missed. But I'd put that number in and understand that that is part of the discussion. And they again drew the same conclusion. Article 5, spiral CT of the C-spine, Journal of Trauma again. They're obsessed with this, and they shoot a lot of films. The problem in this one was, this is a Canadian study, and they looked at some things, and basically what they said was, if we take all the exclusion criteria, it ain't worth bother doing. Just film them. And it ain't worth using a plain film. This is a philosophic difference in the two specialties. We're on one side, and pediatrics is with us on this. Don't do that to young people. Surgeons are saying, downside is too big. Just if you have serious intention, do them all. All right, Article 6. By the way, there's also a time-cost evaluation study here, and it looks at the time spent, people spent, all other kind of stuff. It gave us the same information that every other study doing this has done. It's faster, cheaper to just do a CT. No question. If you take irradiation out of the issue, just CT them. Article 7, CT reduces cost, standard stuff. And again, Brandt's article, Journal of Trauma, surprise, surprise, and he raises the question again of the percentage of inadequate films. Well, let's ask a question here. Is that on everybody? Is that on multiple? How do you define multiple trauma? Is a broken finger and a broken toe multiple trauma? But that's the question. How do you define who's going to be in these studies and who's going to be done? Let's look at Article 9 and star this one. This is a Dutch study. It appeared in the Journal of Trauma, May 2010, but it's Dutch. What does that do? It takes the financial incentive for anything out of the study, right? Because Dutch radiologists are on salary, so they don't care. This is the one that everybody now in trauma is referencing. And they said, and they looked at 1,283 adults with potential C-spine injury, 35%. That number keeps coming back. 35% of the plain films were considered inadequate, and that they would have ordered a CT on them. Okay, we've got these numbers drilled into our head now, so now we got to see what else we're doing. Article 10 is a repeater that, again, looks at the plain film question, says nothing nice about it. Article 12, again, Journal of Trauma, Matthews, and they compared, again, this is a very good study. The sensitivity of the CT scanner, the specificity of the CT scanner, and plain films. CT scan, because they defined it that way, right, picked up 100% of fractures. And it was 99% good that it's ruled out everything else. Plain films picked up 45% of fractures. So I would think about these things very carefully when you're looking at it. Study here from the Hamilton General Hospital. Anybody from Canada? Yeah, the Hamilton General is a very, very reasonable institution. It's associated with McMaster's and that sort of thing. Good people, good quality folks, good radiologists. They said they had a 61% fracture pickup rate. You know, what are you going to do here? And I think that, again, this should now be informing your decision making. If it's grandma who fell out of bed at home and her neck hurts, just shoot the CT. Again, they found the same thing. It's an age thing. You miss old people, you don't miss young people. Move on. Question 2, how good are physical exam protocols in ruling out C-spine fracture? Okay, they've rolled in, they're in front of you. Guy said, how are you at the scene? Fine. Up walking around, yes. My neck hurts now because they strapped me to this board and I don't like it. And by the way, my wallet's being shoved up the back of me and stuff like that. They've all got comments about what's doing on this board. You want to get them out of there. So how good is the exam? What do we actually miss? This is good stuff. If you're looking for a simple answer here, there isn't one. Why? Because we have let's take 3 groups of people. You've come in from a major auto accident. You've starred the windshield, and you're a little confused. Is there any question on that case? No. They go in, you scan their brain, and you scan their neck. Doing the brain and then moving to the neck takes 7 more seconds. They stop the machine, thing goes in, and they just keep moving it down. That case isn't a case because no one challenges that. But now we've got to look at what actually happens. This is blunt trauma patients who benefit from radiography. This is the American Journal of Surgery, 2006. This is done at Allegheny. And you always have to look at the criteria of how people got into the study, right? Who are we talking about? Well, so always ask this. Were there all kinds of other injuries? Did you activate the trauma team? So in some of these papers, they're going to say, in those patients where we activated a trauma team, well, that's a highly selective study, right? What about those other 60 or 70% of trauma patients where you didn't call the trauma team? So always look and see how you got into the study, because then you'll know whether it's actually crap or not. In any event, this is Allegheny General, and they had certain criteria of getting into the study. And then they looked at no complaint. Basically what they said was, not intoxicated, no complaint. You didn't find anything. I mean, and these are people who are looking hard. CTs, all that kind of stuff. You don't find anything, so I would agree with that. If they're awake. Now, what we all know is a lot of these people are young men. Men 3 or 4 times more than women. Between the ages of 18 and 40, who drink too much, right? I mean, this is the crowd that you're asking these questions on. And they're always laying there saying, I'm going to sue you. Okay. Don't you touch me. Okay, yeah, shit. All right. Yeah, are we going to touch them? Yeah. Okay. Are we going to strap them down? Yeah. You going to get sued for that? No. We've looked at this data. You do not get sued. If you have patients with altered mental status who you can constitute and use this phrase, here's your med legal pearl of the morning. If you use the phrase, constitutes a danger to self or others by virtue of the medical condition, I've never seen a case lost in this country. If they ever sue me for strapping you down, I'm going to look at the jury and say, ladies and gentlemen of the jury, did I do that? Yes. I did for them what I would do for anybody I truly cared about, for my mother or my brother. If I am guilty, ladies and gentlemen of the jury, it's of loving too much. And then, yeah. Okay. A couple other things I want to point out here that We don't actually have a study. Obviously, we have not irradiated children on purpose and followed them to see how they did in 21 years with their cancer. It's extrapolated data. That doesn't mean, and we have fairly decent the Hiroshima bomb data and all that kind of stuff, and cancer development after that. Very crude data, but it is real. And you do have to talk to families about this. Their 18-year-old boy is laying there. What are you going to do? It is the risk-benefit analysis, which is not perfect. Let's look at one more aspect, and then my time is actually up. And that's Article 20. This is Dwayne's article. And Dwayne is one of the C-spine gods in the country. There's no question about that. He's done a lot of this. But if you look at this article, they looked at adults, they looked at the clearing, the sensitivity, the specificity, and basically what he says is, can you clear clinically? Yeah. Nexus stuff is okay. Any question, just scan the neck. As far as he's concerned, the plain CT scan, the plain film radiology is dead. He doesn't understand it. He wouldn't know why you would do it. And he has huge sway in the country in trauma. I would think about that a lot.
That's an adult, right?
What?
That's an adult.
Well, he says everybody. He just basically says if you have a serious question, you can't clear, just scan the neck. Now, there are 3 camps in the country. Those who just say, yeah, you're clear, get out, okay? Another one says, I'm just going to scan you liberally and get it. There's another group that says, and if you look at the people from Sick Kids in Toronto, who I respect, very good hospital, they still say the kids' necks are so clear on plain film that we'll take a plain film clearance. And this is where the argument exists that you're going to have to carry on with the families, which way you go. But understand this, it is a philosophic question. It cannot be totally resolved with science because it's what we think may happen 30 years down the road. Let me tell you one of the best things the feds ever did. And I never say anything nice about my federal government, but when they put out all those things and it got coverage in USA Today and, America's largest high school newspaper, right? But everybody started asking this question. When they come in, particularly in a town like Ann Arbor, it's an educated town. They'll say, you're not going to have to shoot x-rays, are you? Now the family is my ally, and I get to say things, I'm so glad I don't have to shoot dangerous ionizing radiation at your child. And so we're seeing this movement, clinical clearing, but if you're serious about it, if I had a kid, and I did have one of these, who was, on the high school gymnastics team, came off the pommel horse directly down on their head. What study did I pick? And now they're in pain. The CT, minimal movement. It gives me the answer, that kid's in pain. By the way, there's no question about if there's a physical finding, if you got somebody whose legs are tingling, something like that, what study are you going to get? The CT. The area of debate is that kid. A little whiny, not quite sure, and what film are you going to use on that one, if you're going to use one at all, and that's, the debate is not resolved. All right, ladies and gentlemen, thank you very much.